All right, let's dive in. Today, we're going to try and navigate the mental health crisis system in Southeast Michigan. And let me tell you, it's a real maze, full of good intentions, but also some really confusing structures and some pretty devastating gaps. It all really boils down to this one simple but incredibly powerful question. When someone you love, or anyone for that matter, is having a mental health emergency and 911 gets called, who should be the person that shows up at their door? For a long, long time, we've only had one answer, but that's finally starting to change. And this new answer is what's called a co-responder model. I mean, on paper, it sounds like the perfect solution, right? You pair a trained, licensed mental health professional with a police officer. The goal? To de-escalate the situation and actually connect people to care, instead of just, connecting them to a jail cell. And that's really the big question we're tackling today. What actually happens when you take this shiny, promising new program and you drop it right into a system that's already stretched thin, already underfunded, and just struggling to keep its head above water? Let's find out. Okay, so let's start with the good news, with this modern solution that's really at the heart of our story. It's a program called CORE, which is short for Core Response Community Outreach. So what's really the big deal here? Well, on the one hand, you've got the traditional response. It's all about scene control. Police show up and their main tools, their main training often lead to either an arrest or a trip to the ER. But the co-responder model, that's a whole different ballgame. The goal isn't control. It's de-escalation. It's diversion. It's about getting that person the right kind of help, not just the most convenient one. Now, the timing here is absolutely critical to understanding this story. The CORE program kicks off in August of 2021. Then, just a few months later, the entire region is just shattered by the Oxford High School shooting. Suddenly, there's this massive, glaring spotlight on the need for mental health services. And right in that same time frame, in December, one person's crisis completely exposed how wide the gap between the promise of this new program and the reality on the ground truly was. But to really get why this program is struggling right out of the gate, you've got to do one thing. You've got to follow the money. And let me tell you, the second you try to figure out who's paying for what and who's actually in charge, the story gets incredibly complicated fast. So check this out. This is just a wild little quirk of local government. A congresswoman gets federal money for police departments inside her district. But because of a simple contract for shared 911 services, residents in a totally different congressional district end up getting the benefit. It shows you how these little local agreements can create these strange backdoors that completely bypass those rigid political lines you see on a map. So you might be asking, who does this clinician actually work for? And this is where things get messy and where accountability gets really fragmented. See, the clinician isn't a cop. They're a licensed medical professional. Their actual employer is this huge public agency, the Oakland Community Health Network, or OCHN. So even though they're in a patrol car with police every day, they don't report to the police. Accountability is split. It's spread out between their boss at OCHN, their partners at the police department, and the state licensing board. It's a tangled web. All right, I want you to just take a second and look at this number. Over $414 million. Just let that sink in. What do you think that number represents in this story? Yeah, that is the annual revenue of OCHN, the public agency right at the center of this whole system. It's a massive, publicly funded organization that's supposed to be managing this entire network of care. Which, of course, brings us to the most obvious question in the world, right? With a budget of nearly $500 million, why does a system on the ground feel like it's constantly starving for resources? Where in the world is all that money going? And now we have to pivot. We have to go from the numbers on a spreadsheet to the actual human experience, because this is where the disconnect becomes just staggering. This one quote, it just says everything. This is from a real person who was hospitalized in December 2021, right when this was all kicking off. It paints a picture not of a safe place to heal, but of a place so desperate and neglectful that someone felt their only option was a hunger strike. It's just traumatizing. And here it is. Here is the catastrophic gap. The program on paper launched in August. Fantastic. But the reality on the ground a few months later, for 4 different communities, a combined population of over 100,000 people, there was one single clinician. And that person wasn't on call 24/7. They worked a standard 40-hour week. It's unbelievable. Now, to be fair, you have to remember the context. December 2021 in Michigan. That was the absolute brutal peak of the Delta variant surge. The problem in the hospitals wasn't a lack of patients, it was a catastrophic lack of staff. I mean, they had already closed 180 beds before the surge even hit because they didn't have people to staff them. So when Delta washed over, nurses from specialty units like psychiatry were getting pulled to cover the overflowing COVID ICUs. The whole system was in a state of collapse. But here's the thing, you can't just blame the pandemic. The people on the front lines, the hospital staff themselves, they knew the system was broken long before COVID. This comment from a staff member to a patient says it all. The crisis was chronic. The pandemic just ripped the bandages off the wounds that were already there. So all of this, it leads you to this really tough question. Is the system just broken, or is it in some ways actually designed to fail, no matter how good the intentions are? Just take a look at the 4 communities that were supposed to be sharing this one single clinician. You've got extremely wealthy suburbs like Birmingham and Bloomfield Township, where the median household income is well over $140,000. And then in that same group, you have Auburn Hills, where the median income is nearly half that, and the poverty rate is 5 or 6 times higher. These are vastly different places with vastly different needs, all sharing one resource. And this brings us to this really fascinating statistical trap. It's called Simpson's paradox. It's basically when a trend looks really good when you lump all the data together, but the moment you break it down into smaller groups, that trend either vanishes or completely reverses. It's a perfect way to hide failure in plain sight. And here's exactly how it can hide the truth. A program manager can stand up and point to a chart like this and say, look, a 90% combined success rate. We're knocking it out of the park. But what they're not showing you is that the incredible success in the wealthy communities is completely masking a critical failure in a place like Auburn Hills, the community that probably needs the most help. Which finally brings us to the unspoken incentives that are driving everything behind the scenes. What's really motivating each part of this system when a crisis call comes in? Well, it's a game of hot potato. Here's how you play. A 911 call comes in. For the police, the institutional goal is to clear that call off their screen and transfer legal and financial liability as fast as possible. So they transport the person to the hospital ER. Boom, potato passed. Now it's the hospital's problem. If the hospital can't admit them, or if there's a criminal charge involved, the potato gets passed again, this time to the county jail. Each step makes perfect sense for the agency doing it, but it's all designed to just move the problem and the person down the line. And that leaves us right here with this one last critical thought. We've just walked through a system that's built for efficiency, for managing risk, for passing liability. But when every single piece of that system is optimized to protect itself, who is left to pay the very, very real human cost of its failures?